Hi, this is Dr. Shweta Chatterjee and I'm going to post videos on cranial and intercranial diseases. So in this video I'm going to talk about brain abscess. And the radiologic features of brain abscess includes: in immunocompetent patients, most brain abscesses are bacterial, streptococci, accounting for the majority. In 20 to 40%, no causative organism is identified. Brain abscesses arise by hematogenous dissemination, penetrating trauma, or direct spread from contiguous infection. The site of an abscess depends on its cause. Frontal sinusitis will result in an abscess in or beneath the adjacent frontal lobe, whilst mastoiditis will give rise to a temporal lobe or cerebellar lesion. Blood-borne infection can occur anywhere in the brain, but has a predilection for the territory of the middle cerebral arteries, particularly the frontoparietal region. A thorough search for predisposing factors should be made. A cardiac cause is frequently overlooked. Abscesses are frequently subcortical or periventricular. 4 stages of development are described: early and late cerebritis and early and late capsule formation. Patients present with fever in 50%, headache and focal neurological deficits. Brain abscesses are multiple in 10 to 50%. On computed tomography (CT), cerebritis appears as ill-defined low attenuation and shows thick ring enhancement that may progress centrally on delayed images. With capsule formation, the abscess shows central low attenuation because of pus or necrotic debris and a rim of slightly higher attenuation surrounded by low attenuation vasogenic edema. After contrast medium, a ring of enhancement corresponds to the capsule. The enhancing rim typically has a smooth inner margin and shows thinning of its medial aspect. In comparison to cerebritis, the center of the abscess never enhances on delayed images. The degree of enhancement is diminished in patients who are immunocompromised or rare on corticosteroid therapy. Abscesses rarely contain gas, most often caused by surgical intervention or communication with the cranial airspace, rarely because of a gas-forming organism. On magnetic resonance imaging (MRI), the signal of the abscess center is between that of CSF (cerebrospinal fluid) and white matter on T1 weighted images, and ISO or slightly hyperintense to CSF on T2 weighted images. On T2 weighted images, the abscess rim is relatively hypointense. It may be slightly hyperintense to white matter on T1 weighted images. The pattern of rim enhancement is similar to that shown by CT. Surrounding vasogenic edema is of low signal on T1 weighted and high signal on T2 weighted images. The abscess center is high signal on diffusion weighted imaging, that is DWI, and low signal on maps of apparent diffusion coefficient because of restricted diffusion in the viscous pus. Though typical, the appearance of a brain abscess as a rim-enhancing mass is nonspecific and may be mimicked by metastasis, glioblastoma, resolving hematoma, or subacute infarct. A thick, irregular ring of enhancement is more suggestive of tumor. Abscesses are more likely to show small satellite lesions. Despite initial hopes that restricted diffusion would reliably distinguish abscess from tumor, reduced ADC has been subsequently reported in metastasis and glioblastomas. Dynamic contrast enhanced perfusion MRI may help distinguish between brain abscess and tumor. Abscesses have a lower relative cerebral blood volume in their enhancing rim than gliomas. The management of brain abscesses can require both medical and neurosurgical therapy. CT diagnosis has been responsible for a marked reduction in the mortality of brain abscesses. Follow-up imaging is recommended at bi-weekly intervals or when new symptoms arise. Sufficient treatment is indicated by resolution of rim enhancement or disappearance of the low signal rim on T2 weighted images. Treatment response may be better assessed with DWI than conventional MRI. Low signal on DWI correlates with a good clinical response, whilst increasing signal implies reaccumulation of pus. Fungal cerebral abscesses are seen most typically in immunocompromised patients. They are radiologically similar to pyogenic abscesses but more likely to show areas of hemorrhage.